Afternoon. Welcome to another session of Healthcare Principles in Practice. I'm Alan Court, the Assistant Dean for Faculty Development. And the HPP series, as you know, is for residents and faculty. If you want CME credit, make sure you click on to the chat, and there is an area where you can actually download and hook up to the link to get CME credit if you are a faculty member. Today, we have Dr. Curtis Carey, the program director for internal medicine. And Dr. Carey is going to speak with us about better handoff, safer care, communication, medical errors, and what we can all do to make sure that our patients are safer. So with that, I will turn it over to you, Dr. Carey.
Good afternoon. Can everybody hear me?
Yes.
Yes.
Perfect. I will apologize ahead of time for any technical issues. I'm doing this at a different location than I normally use Zoom, but I think that we should be good to go. This is a topic that I'm hoping is not a total snooze fest virtually, but I think it's very important, as Dr. Court was saying, because its emphasis is in enhancement of patient safety and improving the care experience for all parties, caregiver and patient alike. If you look at what a handoff is defined as, I picked the definition as described by the Joint Commission in a report. They have some plain language that I think was easy to understand, that a handoff is a transfer and acceptance. And those are two key words. You're transferring care, and then someone is accepting that responsibility, and it has to be done through effective communication. It's a real-time process of passing patient-specific information from one caregiver to another, or from one team of caregivers to another team, for the purpose of ensuring the continuity and safety of the patient's care. So you can tell by that simple couple sentences that it's an essential process. It involves both a sender and a receiver, and the purpose is to ensure continuity and safety. If we look at just handoffs, a little bit of background on that. When a handoff is successfully completed, the next person responsible for the patient has the necessary information to inform care for that specific patient. In a study by Tucker and Edmondson, missing or incorrect information was one of 5 broad types of healthcare problems or process failures encountered by nurses. Lapses in handoffs impact all groups of healthcare clinicians, physicians, nurses, allied health professionals, and non-clinicians, including transportation staff. Handoffs between healthcare workers occur hundreds to thousands of times each day, creating opportunities to identify effective handoff communications. The Joint Commission identified inadequate communication as the 3rd most frequently identified root cause for a Sentinel event in 2014 and 2015. Good communication is a part of patient care and leadership standards. The challenge in completing a successful handoff is knowing what information is most important and how to convey that information in a clear and concise manner appropriate for each patient's circumstances. The literature is replete with articles focusing on the use of handoff tools, and healthcare professionals have developed and validated a variety of handoff tools that provide a shared mental model to help complete a patient handoff. Examples of some well-known handoff tools for clinicians include SBAR and IPASS. And for clinical and non-clinical staff, the Ticket to Ride tool used when transporting patients. Handoff tools help clinicians gather needed information and pass it on to other healthcare workers. And it is an integral part of our healthcare practice. And when it fails, it can be devastating. When we look at some of the cited barriers for handoff, you'll see some categories that we'll talk about through this presentation. It can be communication deficits, where you have missing or incomplete information, use of unclear language, such as abbreviations and acronyms, or similar sounding medication names, differences in communication patterns or language and cultural differences, unclear roles and responsibilities of team members, lack of attention or responsiveness, lack of mutual respect or support, unorganized or lengthy reports, or incorrect, extraneous, or irrelevant information all fall under communication deficits. Inconsistent processes could mean that there's no formal process in place. There's a lack of standardization. We have multiple handoff tools used. The process is too time consuming, or the reports are too long, or if it's relying on written notes, they're illegible. So that could be inconsistent processes. Environmental distractions could be a lack of time, an inability to follow up or share additional information, excessive noise or activity, including background noise, frequent transfers or high census volumes, complex patients with high acuity or new acute care situation requiring immediate care, interruptions, distractions, or multitasking, lack of privacy, staff fatigue or stress, poor lighting, or you have electronic device failure. Those could be environmental distractions. Insufficient training and education can also be a factor. Lack of resources to implement a handoff program and inadequate or no handoff training program. And then you have leadership and staffing challenges. You have lack of leadership support, different levels of staff experience and expertise, staffing challenges, which can be too few members, high staff turnover, missing or unclear handoff policies and procedures, lack of teamwork and mutual respect, or cognitive bias. So that was just a brief overview that I wanted to throw out, because throughout this presentation, we'll talk about barriers and we'll talk about some of those key buzzwords. But you can see, as by us having this presentation, we're trying to lay and continue a foundation to where you guys have exposure to effective handovers. We have some amount of standardization, and we are empowering you to understand and use the IPASS system. And you can think to yourself, in each of your service lines, how well do we do handoffs here? Have you seen them and participated in them? Do you feel comfortable with them? Do you feel like you're able to do them well? Are all questions you should ask yourself, no matter your level of training, and you should ask yourself as a self-analysis as you go through residency or your faculty career. The Joint Commission, as I said before, did issue a Sentinel event alert that many people cite. This was a communication that was sent out on September 12th, 2017. They did cite that a potential for patient harm from the minor to the severe is introduced when the receiver gets information that is inaccurate, incomplete, not timely, misinterpreted, or otherwise not what is needed. This alert that they sent out was both to senders and receivers, which I think highlights the importance of a handoff. It's two parties, someone giving information, someone accepting information, both parties with mutual interest in doing it well. They did cite, as far as graduate medical education, a study by the ACGME said that 69% of clinical learning environments did not have a standardized handoff process, and only 20% had some standardization. And I'm sure that Dr. Ford can tell you a little bit about the emphasis of the clinical learning environmental review. And it was implemented to get at some of these broad scope things, such as handoffs in institutions. You can look at Sentinel events. We use DNV at Erlanger. The Joint Commission is a little bit more widely used, same kind of concept. These are events that are reported, but you should note that reporting of most Sentinel events to the Joint Commission is voluntary and represents only a small proportion of actual events that happen. Therefore, the root cause data that are presented are not epidemiologic data sets, and no conclusions should be drawn, because you can't really get to the actual relative frequency of them and what they do over time. But in 2011 through 13, and in data that I mentioned in my dialogue, you can see that communication is always near the top of events. Sometimes it has been noted to be one of the leading causes. Shorter work hours have led to increased handoffs. And then we have to accept that we work as a team and not individuals. So there's multiple moving parts in this. Improving communication is essential, because communication failures are a preventable thing that we can fix that cause Sentinel events. If you look from a fiscal aspect of it, medical errors are something that cost the system and the users a lot. It costs in deaths, which you can't put a price on, and it costs, if you could, in mortality and disability cost. If you wanted to put a number on it, the estimate that I have here from over 10 years ago is almost $20 billion. If you look at some of the litigation involved in it, you'll see that communication and malpractice cases is a big deal. There's a lot of cases with communication factors. There's a lot of money involved. A lot of it has to do with ineffective ability to communicate the patient's condition, failure to follow through and read the medical record, or poor relationships and rapport. So communication is vital. So how do we get to a new day to where we can feel comfortable that we do handoffs in a secure, in a confident way? And we're going to talk a little bit about the IPASS method. You'll see in this presentation, team steps. Team steps stands for Team Strategies and Tools to Enhance Performance and Patient Safety, and was developed by the Department of Defense Patient Safety Program in collaboration with the Agency for Healthcare Research and Quality. It's an evidence-based framework based on over 25 years of research on team performance in a variety of different areas. It's being rolled out across the nation in an effort to improve quality and patient safety. It's 4 specific skills that are characterized by high-performing teams: effective leadership, structured communication, situational awareness, and mutual support. The employment of this leads to success, and we ask that you all take a little bit of time to know this phrasing and these 4 factors: leadership, communication, situational awareness, and mutual support. We want to give you the tools to improve handover quality and efficiency. We want, at all possible, to standardize the process across teams, across disciplines, and throughout our healthcare environment. And we want to improve skills and succinct patient presentation and situational awareness. Keyword there being succinct. You get the information to the other party without a verbose amount of dialogue that causes disinterest and harm to the patient down the road. And then through this, we can improve patient safety, which I'm sure is what many of us always have in our mind. We want you to take pride in your team and in your handoffs, take pride in your night coverage, and then take care of your patients, give them a safe environment. Our goal is to not make this harder or make it last longer. It's to make the handoff safer and more effective. You'll talk about a shared mental model sometimes in this. In order for a team to function effectively, all individuals on the team must be aware of what is going on at all levels among members, staff, patients, and families. Each individual activity assesses the clinical situation, which is the skill of situation monitoring. When you're assessing the clinical situation and all the factors involved in doing so accurately and efficiently, you can be said to have situational awareness. When all team members have situational awareness and are sharing their awareness with other members, a shared mental model is obtained. So that's what the key of that is. All members have this awareness and are able to share it. The shared mental model is essential among team members during the handoff process, as the day team and night team are really one complete team taking care of patients. Patient safety will be achieved when these teams have a shared mental model. An example of a model that's not shared would be you put your kid on the bus in the morning and then you thought the plan was to pick them up at school and the kid gets on the bus. So you could see the obvious disconnect there. And that's probably just a really common way to say clear communication and expectations weren't met. You do want to cross monitor. You can recall in the training, in your training, sometimes when a junior resident was actively assessing the situation and recognized a potential error when entering the room, they may not have let the procedure proceed until the error was corrected. That person was actively cross-monitoring the actions of those above and below and beside him, such as the senior resident and nurse. When you are cross-monitoring, you are monitoring the actions of your team members to prevent errors themselves and correcting them that have the potential to lead to adverse events, and you correct them in real time. You are helping each other maintain his or her situational awareness. In handoffs, the night team or cross-covering team is looking out for the day team and vice versa. Everyone is responsible for the patients. So remember that we are trying the shared mental model and that we're watching each other's backs, monitoring our team members' actions, and helping to always maintain and facilitate situational awareness. Some principles of that could be briefs and debriefs. Briefs are held for planning purposes and are sometimes referred to as team meetings. Items that might be included in a team brief are listed on the slide. As you can see, it is somewhat analogous to a pre-flight checklist used in aviation. Can you envision how a brief might be beneficial to your patient care team on the inpatient service, for example? As a corollary to the brief, the debrief is a recap of a situation or the day's events for purposes of process improvement. Debriefs are the most effective when they are conducted in an environment where honest mistakes are viewed as learning opportunities. So defensive stances or looking to call someone out is not the goal of a debrief. We're looking for a learning opportunity here to where non-malicious mistakes are being viewed. They should be brief, 3 minutes or less, and they should be facilitated by a team leader. To maintain effectiveness, they should not be forums for assigning blame or failure to specific individuals. So if some of you have a negative connotation in debriefs, or if you've been part of debriefs and they've been a negative experience, that is not necessarily a function of the debrief, but the leadership of who provided the debrief. It is meant to be a process improvement tool. It might be necessary at times to conduct a complete process review and system redesign if the same issues or events continue to recur, but they're essential. You want to get at, was there clear communication? Did everyone understand what role they played? Was the workload too high? Was there assistance offered? And was feedback given? And then you do want to continue this kind of closed loop communication, check back. We want to verify and validate. Those are the two big words, verify and validate. The strategy involves the sender initiating a message and the receiver accepting. Accepting is best noted when it's verbally understood. Nodding heads or check marks or whatever is not necessarily the best. Accepting should be one of those things to where you're on the plane and the stewardess asks you that you're in the exit row to verbally acknowledge. That is a tool that's why they're doing what they're doing. They're accepting and confirming that the message was communicated and that you not only heard it, but you understood it. And that is the purpose of closed loop communication. If you put it all together, it will work in a way that enhances patient safety. You'll cross monitor, use briefs and debriefs, huddle, and then check back when things change. And this is a dynamic process, but it works. It works not only in the healthcare industry, it works in other industries. So we urge you to look at this terminology and use it. And as we said before, there's plenty of barriers, but if you use the tools and strategies of briefing, debriefing, huddling, cross-monitoring, closed loop communication, feedback, checkbacks, and handoffs, you're going to have an outcome, hopefully, of better team performance, a shared mental model, and increased patient safety. That is the most important aspect. This is why we do what we do, and we focus so much time and energy on this. We want the patient experience to be as safe and evidence-based as possible. You would not want yourself or your family members or your loved ones in situations where they're inherently in an unsafe environment because people failed to take the time to effectively communicate. So communication and teamwork come together in the handoff process. What could be an effective handoff is got many parts to it. You have to have a leader in an assigned role. So people throwing out handoffs or one person trying to dominate the session or kind of push their own agenda because they want to leave early or they want to do something else is not necessarily. So it needs to have a leader. I have urged people in pediatrics and in internal medicine that the leader should be the receiver, because that is the person that is synthesizing the information. But each team should look at their system and identify a leader for handoffs. And it needs to be an unambiguous transfer of responsibility. You are accepting responsibility. The team doesn't end when one shift ends. The team is continual. It needs to happen to where there's protected time and space and in a standardized format. It has to be up to date, has to be accurate, and it has to be relevant. You have a lot of moving pieces. You have to know your patients. You have to know who's on the team and what their clinical experience is. You have to know where everybody is in their level of training. And then you should implore people to have the shared mental model through active participation. The receiver should receive and be part of it. They should not be silent and off in a corner accepting pieces of paper with rapid fire information being presented. For it to be effective when you're doing a verbal handoff, it needs to happen face to face or camera to camera or whatever we need to do. But you should be able to look at body language, is what this is talking at, and inflection tones and all this stuff that is in how we communicate with each other. It needs to have a structured format, and it needs to start at a higher level and go granular as needed. It needs to be appropriately paced, and it needs to be closed loop and a shared mental model. You should also utilize a printed handoff document. Epic does have a handoff document that each person should be familiar with at Erlanger in our College of Medicine, and you should feel comfortable using it. Some of us supplement that with an additional Word document or other chart or other printed thing. The goal of that is to not put everything on that document and hand that document to somebody. This is to supplement the verbal handoff. It allows them to follow along. It allows them to take notes, and it provides some succinct, specific, accurate, up-to-date factors for them that they can check up on. We should never, ever hand off and just hand someone a document. And updating this printed document is something that should happen in real time and throughout the day. So on your structured verbal handoff, you're going to begin with an overview of the entire service. You're going to be in a place to where you can be not interrupted, dings, bangs, goofy conversations, jokes, whatever is not going to be a limitation, because sometimes the receiver, if all they can remember is what was going on in the background, someone playing foosball, someone eating a bag of Doritos, and they have a patient that they missed something on. You don't want that to be the limitation of safety. We want to use a mnemonic or a system, whether it be SBAR or iPass. We are promoting iPass, but you want to use it. You want to use it to where all of our team members are trained on it and use it well and use it daily. And we want closed loop communication. You want to supplement this with a printed handoff document, and it does not need to be a printout of someone's H&P. You're not going to carry around War and Peace. You want a printed document that supplements the verbal handoff, has the important elements of the patient from the medical record, and is current. It doesn't have a CBC from 5 days ago that never gets updated. You want to employ that you have these high-level skills of summarizing concisely, focused, what the diagnosis is, what qualifiers you can use, and then you're stopping and making sure that the person you're giving handoff to is synthesizing and receiving it in an effective way. And you also would want to have contingency planning. If something happens, what's the next step? And you want to be as specific as possible. You don't want to say, if they bleed, go check on them and replace. What do they replace with? What is the volume? What is the standard? If a lab value or a vital sign is out of a parameter that you want them to intervene, tell them what the intervention is and what should be the first line of intervention should be. You want to problem solve before things go wrong. You want to know what they can use, when they can use it, and you want to give them a clear picture of who could be the sickest patient, who could be that worrisome person. And then you want to clearly let them know if you need to elevate it through the chain of command, what that is. IPASS is something that we have used in pediatrics for quite some time, and other places have picked up globally. We have used it here now in pediatrics, family medicine, and internal medicine for over a year or two, and have had great success with it as far as implementing it. Now, its consistency and its validity, I could ask each resident and probably get a different answer, but it is a system that is nationally known. It has data behind it, and we feel that it works well. If you look at the acronym, the I is illness severity, and we'll get into this patient description. Are they stable, unstable, somebody I need to watch? Then you're going to move into the patient summary, and it needs to be a summary statement. What happened up to getting admitted, pertinent hospital course, what our assessment and plan is. But it should not be reflective of an H&P that was written in great detail. You want a summary statement. So in the word summary, you're taking all these things and quantifying it down into a level of information that can be clearly and concisely displayed and given to someone else. When you look at the A, it's an action list. What do I need to do? The receiver needs to know what they need to do, when they need to do it, and who is doing it if multiple people. Now, obviously, if you're handing it over to one person, that one person knows, but many of our night teams could be more than one team member, or it could be a delegation to where one of our healthcare team members in another field is helping us with this, whether it be nursing, physical therapy, case management, social work. So what do they need to do, when they need to do it, and who is going to own this task? The first S is the situational awareness and contingency planning. You need to figure out what you're going to do if something happens and what you're going to do next. So the I, the P, the A, and the first S are stuff we do every day inherently, but we may not communicate them clearly and concisely. The handoff has to have that clear and conciseness. You have to be able to say how sick someone is, why they're here, what your handoff person needs to do, and how they can effectively contingency plan for what if something goes wrong. The last S I've always professed is the most important, and it's last because you need to make sure that you're handing over someone who has received it effectively. They should summarize in some way what they heard. They should feel free and empowered to ask questions. And for especially the action list and the contingency planning part, they should restate what needs to happen, and if something goes wrong, what they're going to do. Then at the end of that, both parties should feel like it went well, it's understood, and nothing was missed. The synthesis by the receiver should always include a verbal acceptance. It should never be a nod or just a okay. It should be like, this patient was here for this. This is what I'm going to do. This is something that might happen, and this is what I'm going to do if it does happen. And I accept now the care of this patient. IPASS uses the labels of stable, watcher, and unstable. So stable and unstable can be defined by service lines and places. Surgeons may be different in how they define what is stable and unstable from pediatricians. Emergency medicine physicians may be different than internal medicine physicians. But these terms are subjective, and the receiver can set these terms based on what they have gotten and how they feel their support through the night will go and what kind of team they're in. The word watcher is any clinician's gut feeling that a patient is at a risk of deterioration or close to the edge. And it should be one of those things to where it's implied that if it's a watcher, If you're called about the patient, you need to go immediately to the bedside. You should be checking on them. They have a higher rate of decompensation than others. Some systems will use scoring systems. Some people say sick, not sick, but you need to go ahead, have a system to where this severity is easily understood. And I think pediatrics have done it for quite some time, and the nurses are empowered to even understand that stable, watch, or unstable, and they have protocols in place and nursing care ratios that help better care for the patient be established, which is the goal of this. Now that that summary can be where people get lost in this voluminous amount of information, and you could get this glazed over feeling. But the goal of this is to be succinct. We can talk about why they got admitted, the events leading up to it, the assessment, the hospitalization, but all that, if it goes on and on and on, it's not going to get to it. So it needs to have the focus of being succinct, concise, qualified, and active issues. No one needs to belabor a social aspect that is only pertinent to a case management issue that is not going to be at play at night. Sometimes we get focused on things that may be unique to each patient and they could be worth talking about. But remember, the handoff is most effective when it's not bogged down by extraneous information. So when you give this summary statement, it needs to be succinct, it needs to be concise, and it needs to focus on active issues. If it doesn't do that, you're going to lead into people not paying attention or people not understanding the relevant information that they need to do. The A is where the ears should perk up. That's the action list. It should say what needs to be done, what priority is it, when it needs to be done, who's going to do it, has anything been initiated, and it should have a closed loop and have something to say it was complete. It should, the action list doesn't need to carry over day to day. It doesn't need to be redundant. It needs to be up to date, pertinent. If nothing is there, the statement nothing to do is fine to use, but you should stand by that. You should make sure that is the case. And once you set that as an expectation and the receiver receives it, you can add back to it and say that they're going to naturally think of these things the same way. So the action list is your to-do list. It needs to have a timeline. It needs to have prioritization. It needs to have assigned roles. It needs to know when it gets done. And then if there's nothing to do, then say there's nothing to do. Situational awareness needs to happen at a team and a patient level. The team should know the status of the patients, who's on the team, and where the patient is, what floor they're on, what the nursing capacity is. It may be, also how tired the team is. Have we had a high workload? Are we stressed? And then everybody should feel free to comment on those factors and clearly communicate with the receiving team what had been going on that day and what the team level is. And the receiving team needs to also say, we have a lot going on. There's a lot of sick patients. These other things have been handed off. So we should all be on the same page as to what could be the level of performance of both parties. And then at a patient level, know what is going on with the patient, the status of their disease, progress towards the goals of hospitalization, what forth. When you get to the contingency planning thing, the effectiveness of it is where you identify concerns, think about what might go wrong and clearly articulate that and define it with a plan, with a list of interventions that have and have not worked in the past, and what help can be available. If the patient is stable and you've labeled them as a nothing to do stable patient, it is fine to say, I don't anticipate anything will go wrong. But you should have had a thorough and rigorous mental assessment of the patient where you've looked at concerns, thought about it, and have reviewed what has happened in the last 24 to 48 hours to come up with that statement. Contingency plans, what patients are worrisome, who's the sickest, who's at risk, what may go wrong, what you need to do, such as if an asthmatic develops worsening distress, begin continuous albuterol therapy might be a statement that you could use. Resources, What is the call? What is the chain of command available? Is there a fellow available? Is there another senior available? Is there a teammate in an ICU available? Are there other enhanced professionals such as respiratory therapy, access professionals for lines and different things from nursing or other service lines that can be used? What different concerns are at play from both nursing and family that may set off into the other shift could also be discussed. And then synthesis. The receiver should be able to concisely state the essential information back to the person that gave it to them. And then they want to, in that, clarify anything that was unsure to them and be part of handover. Melting into the background, looking disinterested is never helpful. Active engagement, verbal responses, and being a team member as a synthesizer is highly important, and everyone should do that. This is a team sport. Team handoff is the gold standard. We should say, does it really make sense that we have the most junior people handing off to the most junior people without direct supervision? Probably not. So the whole team should be present in handover. Some situations may necessitate different levels of handoffs for different situations, but in general, we should look at handing over of patient care as a team sport. The whole team should be there when we do this handoff, and we should all begin to have active roles in this. So think about it in your service line. Think about it in its granular details. Where do we do the handoffs? Do we fit this kind of culture of, is it a quiet place with minimal interruptions? When do we do them? Are there scheduled times? Do we try to protect that time? As all parties present, should we do more briefings and debriefings? When and how we should do them? So if you look at, we've had experience with this through the years, and you can see the data a little bit, that residents usually will support IPASS implementation, but then as time goes on, adherence is always influenced by patient type, what's going on, team factors. And then when they cite why they're not able to adhere to it, some of them say that they don't use all the elements and that typical barriers pop back up, and that's time, familiarity with patients, and then the complexity of the patient. So think about the handovers that you do in your service line. Do you also share what these studies have shown for residents? How can we do them better? What resources do you need? As an institution, and as part of the focus on the clinical learning environment, handoffs are essential. We should provide you with resources and advocacy to make sure that you have time to do them well, because when they're done well, you're increasing the safety level for all parties, patients, physicians, nurses, allied health professionals, and consumers. So please think about this. I wanted this to be a kind of review. The Zoom doesn't lead to the interaction of how we've done before. We've looked at different processes, compared, contrasted. I think that's somewhat lost. So I have done this in a way to where you could use this, go back to this recording, look at each service line, but I think it might be an important process, and it might be something as an institution that we could report on as far as our annual program evaluations and how we do things, our handover process, and then do best practices, and we can even do some more simulation experiences later. How you document competence is always going to come up with this. Some of us use a facilitation and orientation with role modeling, or kind of using an OSCE type situation. Other people do observations of real-time thing. Those documents important, but they're only important if they're embraced and they're used in the way they were intended, to where all people have active roles and we have honest and clear communication and detailed explanation of what went well and what did not go well, and what is always our improvement strategy. So with that, I will end my dialogue and allow for some questions. And I wanted to thank you guys for bearing with me, and to all the residents, thanks for all your hard work. You do quite a bit of heavy lifting, 99.9% of it in my view, and you're the reason that I have stayed in Chattanooga, and I thank you all for your hard work. So with that, I'll end my discussion and open the floor up for questions.
Hey, sir. Thank you so much for giving us this talk. I had a quick question about handing over patients who are like unstable. I know as a service team, we'll hand over those patients at bedside for patients who are unstable. Do you have any other tips and suggestions? Thank you.
I think that that's an excellent question. And one of the things that you popped in on is you definitely want to make sure that you set a time limit for handover. So I always tell, especially in pediatrics, when we do the workshops, that if handover is at 5, it needs to end by 5:30, and everyone needs to know the time constraints involved. And we also need to make sure we respect everyone's time, because a lot of our program directors and a lot of our administration are going to go out to nursing, and other people say, hey, this time is protected. But for those cases to where you have the most complexity and you need to reinforce things with visuals or with aspects of high acuity complex patients, it's a good tool to use at the bedside to do that. It just needs to be one of those things to where that probably needs to be done either at the end or in the beginning, and that the other people that are engaged in the handover process don't interact with that. I see that fail when people want to use it and then it goes into a long thought out thing that goes over these kind of constructs of what we said that we were going to do. The written tool in those patients can be really helpful, and that is where you can get to granular details and give that to them. And then you throw out the piece of information. This patient's highly complex. We expect things might get above what we've described. Call the attending, call this person, and do it in a way to where it's done early. And that way it can be reinforced later back at the bedside with a party or over the phone with you looking at the patient. And that way you kind of give yourself a better chance for success.
Thank you.
All right.
Curtis, what do you see as the biggest area that does not work well, or where people have the biggest challenge with using IPASS?
I think the biggest challenge that I have seen is people don't clearly embrace it, and they try to do too much or too little with it, and they don't follow through with the setting and the standards that they did. So they're not giving themselves time limits, they're not in active engagement, and they don't speak openly and freely. So I think we should develop situations to where we are able to communicate. We do it in a way that can be done in a limited, a defined amount of time, and in ways to where it can be effective, clear, and to the point without emotion or any kind of lability that comes into it that affects it on a human level.
The other question I have is, one of the keys to success is actually having either a senior chief resident or a faculty member actually observing the IPASS. Is that happening within any of the groups that are using IPASS?
It happens in a perfunctory way and a lot of things, to where we set a standard that some may have to be observed. I did a literature review on is the more the attendings involved, do you get better outcomes? And the stuff that I had found like the attending, when they get involved at higher levels to where they're at a side-to-side pace with a resident wasn't viewed favorably. So we probably should think about ways to where it's more consistent observation and we utilize more peer-to-peer evaluations in conjunction with those higher level evaluations. Because I think from a coaching aspect, you might be more reflective and dig a little deeper at a side-to-side level than a supervisor to resident level.
So you're also saying that when the attending's there, the performance may be a little different just because the attending is present in the room.
Right.
And doing it with another resident may be better. The other question is if we ever get to the point we can actually use our simulation areas, actually being able to do it with simulation may also help, correct?
Yeah, and then people that do simulation, sometimes people that do well in simulation may not do well in day-to-day activities. So it should be a simulation that approximates as much as possible. So sometimes when you simulate, it might be better to kind of go all in and not just use the basic script and then go to the time of day that it needs to happen. You try to kind of get at that fatigue level and different aspects than just the random noon or 8 a.m. Thing that sometimes simulation does.
Would it be better to even have recordings done of regular handoffs and have them done on a regular but not scheduled basis?
I think that I've seen some programs and literature do that, and I think that it works well when it's multiple recordings in a longitudinal way in a portfolio that's evaluated more than at one point in time, and it allows for some self-analysis, and it also helps to look at yourself on video and get over the whole kind of just how awkward it is in the beginning, because when you do it several times, it's more helpful.
Other questions for Curtis? Dr. Carey, the other thing that I have found in the past was that one of the biggest problems has been to have people actually take the time and feel comfortable with doing the repeat back. You know, a lot of people feel, oh, you know, we've got other patients to get onto and discuss, and they don't really take the time to do the repeat back, you know, to verify that they have heard what has been said. What's been your experience?
I think that's true, but what I try to emphasize is that when you look at the acronym for SBAR, IPASS, they're all capitalized. So it's kind of like you use vaccines. I mean, little letters mean something compared to big things, but when it's all big, they're all important. They all have a role to play. So I tell them that last S is not an apostrophe little s, it is a big S. It's the same size as the P. So we shouldn't get lost in all that patient summary and forget that the synthesis is, and we should place equal emphasis on it. And the equal emphasis should be the amount of time devoted to it. But I think that sometimes falls into a leadership organization early on. People that are got that leadership ability should emphasize that, and then note when it doesn't happen and intervene. So that way it's part of our cultural kind of scheme that last S is as important or more important than anything else.
At this point, any other questions or comments for Dr. Carey? Well, remember to go ahead, for those of you who may be faculty, to click on and get your CME credits. And with that, I don't see any other questions at this point. I don't think there's anything in the chat. Let me just look for a second. No, I don't see anything else in the chat. So with that being said, I want to thank all of you. I want to thank Dr. Carey for doing a wonderful job in walking through this discussion about IPASS, patient safety, and communication. I want to wish you all to have a great day. Stay safe, stay healthy, and thank you for attending.